I'm Dr. Mika Sinanan. I'm a professor in the Department of Surgery, and this has been really a tremendous session so far. Dr. Saurabh Khandelwal is a colleague of mine in the Department of Surgery. He's an assistant professor at the UW School of Medicine and director of Bariatric Surgery. He co-directs our UW Medicine Weight Loss Management Center. The Weight Loss Management Center, as he will tell you in more detail, is at the forefront of weight loss surgery and one of only 6 centers that has been funded by the National Institutes of Health as a center of expertise in the outcomes of bariatric surgery. Dr. Khandelwal has a family that keeps him very busy when he's not working with us. His clinical interests include the minimally invasive surgical approach to bariatric surgery, as he will describe to you, as well as esophageal surgery. He has authored many publications, including The Evolution of Bariatric Surgery, a Historical Perspective, and is considered an expert speaker, he'll prove that tonight, on bariatric surgery. He earned his medical degree in Chicago from Rush Medical College, completed his internship and residency at Northwestern, also in Chicago, and completed a fellowship in advanced minimally invasive surgery here at the university. We hired him the minute he finished his fellowship. Please join me in welcome Dr. Khandelwal.
Dr. Sinanan, thank you for that introduction, and thank you all for letting me have the privilege of speaking to you all tonight. This has been a great session, and we're going to cap it up with a discussion about obesity and how we can actually address it through bariatric surgery. So I have no disclosures for this. Briefly, kind of giving an overview, we're going to talk about obesity and its effects on mortality and disease. We're going to discuss the common operations that we do in the modern era. We're going to briefly talk about how we select patients for these operations, and also end with some of the future directions where the field is going. So first, some definitions. You've seen some of these before. Obesity is graded with grades 1 through possibly 4, and that red box is where we go from overweight above it to obese. So a BMI of 30 to 34.9, and a BMI of 35 and higher is considered morbidly obese. And that yellow box, which represents morbidly obese patients, that represents the group of patients for which surgical intervention is currently warranted. Dr. Scher and Dr. Hirsch showed you some slides about the incidence of diabetes and obesity. These are some of the latest statistics. So 8% of infants and toddlers are obese, about 17% of young children and adolescents, and a little bit under 35% of adults age 20 or greater. We have seen a slight decrease in obesity in 2 to 5-year-olds. Some people think Michelle Obama has something to do with that. We have, however, seen a significant increase in elderly women, a pretty significant jump from 31.5% to 38%. If you look at it along different ethnicities, non-Hispanic blacks have the highest rates of obesity, and non-Hispanic Asians have the lowest rates. The skinniest state, Colorado, 20.5%, and the fattest state, Louisiana, 34.7%. Why is it such a big problem? Well, if you look at this somewhat complicated slide, obesity really affects every organ system from head to toe. When we see patients in our clinic, they don't suffer from one of these conditions, but often many of these conditions. And even more distressing, if you look at the bottom of that slide, we're starting to see some of the long-term effects of obesity, especially as it relates to cancer. Some estimates put that 1 in every 7 cancer deaths in men and 1 in every 5 in women are going to be related to a tumor or malignancy that was exacerbated by obesity. Most of the major organ systems, we're going to see a rise in cancer due to obesity, and they estimate by 2030 we're probably going to see about 500,000 additional cases of cancer directly related to obesity and its impact on cancer. But as Dr. Scher showed you, even a small reduction in weight can improve your health. Similarly, a small reduction in your BMI can also reduce the risk, and if the population reduces their BMI by 1 percentage point, that would probably take out 100,000 new cases of cancer for this estimation. If you look at it socially, economically, health-wise, even with our armed forces, Obesity really touches every aspect of our society. And currently it's estimated, and these are fairly conservative estimates, that direct costs related to treating obesity and associated conditions run in excess of $160 billion. The obese patient spends more on an annual basis in their health care compared to a normal weight adult, and this represents about a tenth of our national health care spending, which you all know is significantly higher than any other developed country with similar health care. So we hear about a lot of things in the news, bird flu, global warming, this and that, but really this is a really big problem. It just doesn't get some of the acute press that some of these other issues get. It kind of looms in the background. Why does it matter? Well, we know as your weight goes up, your risk of dying actually increases. I apologize, the title of this is probably the same color as the top bar, but what this is showing is a relative risk of all-cause mortality or death in U.S. men and women. And you see, once you get to that area between 30 and 35, and especially beyond 35, the risk of all-cause mortality, or the risk of dying, really starts to increase. So this is something that really needs to be intervened on, and this forms the basis of patient selection for bariatric surgery. If you look, take a 40-year-old person, and I'm almost 40 years old, so I sometimes assess myself like this. Look at someone's weight at that age. If they're overweight, which is a BMI between 25 and 29.9, they're going to shave 3 years off of their expected life. If you're obese, so between 30 and 35, 6 to 7 years of lost life. And if you're obese and smoking, more than a decade of life lost. And some folks thinks that this is possibly the first true decline in life expectancy since the Industrial Revolution. So we've had 120 years of medical advances, and now because of this massive health problem, we are starting to see how some of that might be undone. So the need to lose weight is obvious, and what is the best way to achieve sustained weight loss? Well, dieting and exercising are hard, and most people don't like to do difficult things. But I'll tell you, surgery is not a walk in the park either. If you can't read the caption, this is a doctor talking to a patient. He says, well, yes, it's a routine procedure if you routinely have someone slice open your body with sharp instruments and then fiddle with your insides. And in a nutshell, that's really what we are doing in bariatric surgery. But although it's not quote-unquote natural, it's extraordinarily effective. But it does require a lifetime commitment to appropriate dieting, exercise, and routine follow-up. The bottom line is these are really behavioral change operations. They do not really cause people to lose weight just in and of themselves. None of these operations are going to make people look and feel like they're 18 again. But when you combine them with discipline, with appropriate dieting, with a commitment to exercise and routine follow-up, you can really achieve some remarkable results with these operations. This is the Swedish obese subject study, and it's one of the longest running studies in the world looking at different interventions. And what they did, they compared about 2,000 people in each group, one group which had intensive medical management to try to lose weight, lifestyle interventions, and the other group which had one of 3 different operations. RYGB is the gastric bypass, VBG is the band, a vertical band, which is no longer done, and the bottom one, LAGB, is the lat band, so to speak. And they followed these patients for more than 20 years. And if you look at the long-term results, they're pretty remarkable. The non-surgical group, despite having pretty good follow-up in a tightly integrated healthcare system in Northern Europe, they had negligible weight loss, plus or minus 2%. The folks who had gastric bypass, even 15 years out, had reliably lost and kept off a third of their total weight. So they're pretty powerful, and they can achieve long-term sustained weight loss. More impressive, and these are other studies which have looked specifically at gastric bypass, which is really considered the gold standard operation. Besides losing weight, you can have a tremendous positive impact and risk reduction in various areas of health. In patients who underwent bypass and lost weight successfully, they compared these folks with, again, another control group that did not have surgery. The folks that had surgery, they reduced their all-cause mortality or risk of dying by 40%, 56% reduction in cardiovascular-related deaths, 92% reduction in diabetes-related deaths, and a 60% reduction in cancer-related deaths. So really powerful stuff. And this slide really sums up why we do these operations. It's not just to get people to lose weight, but all of the other medical problems that come with that gaining of weight. A lot of these problems can be mitigated or even cured when you get someone to lose weight, a significant amount of weight, and to keep it off. So if you look at common medical problems, and most of the patients that I see come in with, if not all 5 of these, at least 3 to 4, such as diabetes, elevated lipids, high blood pressure, sleep apnea, and GERD, we can achieve a resolution or cure rate for many of these diseases hovering around 2/3 of the time. Well, surgery is pretty radical. I wouldn't want my intestines rearranged if I could avoid it. Is it a safe thing to do? Pretty much. The overall mortality associated with these operations in the modern era is less than 1%. The operations that require creating a new connection in the intestine, and we're going to go through these in a couple minutes, those tend to have the higher risk because you're cutting the intestines and sewing them back together. Many groups have looked at the study, and Dr. Flum, who is one of our renowned researchers and one of the leaders in the LABS study group, which is the longitudinal assessment of bariatric surgery, looked at the safety, and this is right on par with what we see. There's about a 20% complication rate, meaning any complication, big or small. Most of these are related to the surgical wound, blood clots, and other postoperative complications. There's about a 4.5% risk of a major event requiring reintervention, such as an endoscopy, readmission to the hospital, or even a reoperation. Kind of summing up some of the outcomes that I've talked about, this is Dr. John Baker, who's a renowned bariatric surgeon. This is really one of the most durable procedures we have for resolution of these chronic diseases. What other procedure can improve hypertension, heart disease, diabetes, sleep apnea, and high cholesterol? So it really is kind of the Swiss Army knife of general surgery operations. And what are these operations? So most commonly in the modern era, there are really 3 operations that we discuss and do. RYGB, or the gastric bypass, that's really the gold standard, the sleeve gastrectomy, and the laparoscopic adjustable gastric band, more commonly known as the lap band. And how do these operations work? Well, there are really 2 fundamental mechanisms. They restrict how much you can eat by limiting the reservoir capacity of the stomach, and they, to some degree, can also induce malabsorption. Some operations fall cleanly into one of these categories, and some operations straddle both. And I've highlighted the operations that are in red. These are the ones that are commonly done in the modern era. And if you look at the gastric bypass, that's the operation which really offers the benefit of having both of these mechanisms behind it, both restriction and malabsorption. But it's really not that simple. You know, as we're learning more about the very complex cascade of hormones which, work between the gut and the brain and fat stores, there definitely is a neurohormonal effect on energy balance, and that's one of the hottest areas of research, is trying to figure out how do these operations induce those changes, and even more basically, what are those changes? The holy grail would be if we could figure that out, put it in a pill, and I'd be looking for a new job. So we're first going to talk about restrictive procedures. So what these really are doing is just limiting the caloric intake by limiting the reservoir capacity of the stomach. The adult human stomach, when fully distended, can hold 1 to 1.5 liters. That's why you can fit an entire Chipotle burrito into your stomach at once. These restrictive procedures, they tend to lead to more gradual weight loss, so it's not as quick as with a malabsorptive procedure. They tend also not to have as many of the malabsorptive side effects, such as dumping syndrome, and we'll talk about that in a minute. These are technically less demanding procedures. They're safer because they typically don't involve making new connections on the intestine, and they tend to be quicker operations. Some are even outpatient procedures, but most of them are either outpatient or overnight stays. Malabsorptive procedures, for instance, a gastric bypass or a duodenal switch, works in a different way. And what we're doing is we're actually physically altering the flow of food and the enzymes needed to digest that food in the human GI tract. And what it does, it basically decreases the functional length that's available for absorption of nutrients in the gut. These tend to lead to more rapid weight loss, more overall weight loss. As I mentioned before, they involve creating new bowel connections, which are called anastomoses, and they're technically more challenging operations. Behavioral modification can actually result from these operations. So if I do a bypass on someone, what I counsel them on is that you really cannot eat rich foods anymore, sugary foods or fatty foods. those foods with large molecules like sugars and fats will induce dumping. They go eat a candy bar or drink a milkshake, and they'll be running to the bathroom with diarrhea, nausea, bloating, and cramping. That sounds pretty terrible, and it is in the beginning, but it's actually a negative feedback mechanism. If you eat junk food, it's going to make you feel crummy, and most people, after they have a couple of these experiences, they really start to modify their behavior and start making better food choices. So it's all a planned part of how those operations work. I'm going to briefly touch on some of the underlying mechanisms. Dr. Schur and Dr. Hirsch mentioned some of these, but clearly there is a significant neurohormonal effect which these operations can induce. They involve the gut-brain axis involving the reward pathways in the brain. They have both local effects, which are mediated by nerves, and also distant effects mediated by hormones. They affect various hormones which are controlled and secreted by fat stores, by the pancreas, and by the GI tract. Two of the areas which we tend to hear a lot about nowadays, one of the hormones is called ghrelin, which Dr. Schur touched upon. And this is really one of the few hormones which actually stimulates appetite. It's also known as an orexigenic hormone. And immediately after you do a bypass or a sleeve, where you either bypass the front of the gut or you actually cut out the majority of the stomach, we see an immediate drop in ghrelin. So these folks just do not feel as hungry as they did even the day after their operation. Some of these other hormones, such as CCK, GLP-1, and polypeptide YY, these are pro-satiety hormones. They make you feel full and make you not want to go out and eat more. These are increased after some of these operations. And one of the theories as to why that may happen is because if you're bypassing part of the human gut, you're actually delivering food or nutrients more quickly to the end of the gut, and that is thought to have a feedback loop which stimulates these hormones, which kind of puts the brake on things, tells your brain, you know what, I'm satisfied, I don't need to eat anymore. We're going to spend a little bit of time talking specifically about those three operations. So the first one we're going to discuss is the gastric bypass. This is really the gold standard, first described in the 1960s, and both malabsorptive and restrictive. Really the background of the RU and Y is with ulcer surgery. Before I was born, one of the most common things surgeons did was treat ulcer disease. And depending on where the location of the ulcer was, if you had to cut out part of the stomach and recreate things with a RU, which is dragging a piece of the small intestine to the top of the stomach, which is what I do in a bypass, they noticed that these patients lost weight. That obviously wasn't the point of that operation, but this side effect was clearly seen. People caught on and said, well, let's try using this specifically for weight loss. And eventually it was performed laparoscopically with small little keyhole incisions, and that's really what started the modern era of weight loss surgery. Worldwide, it's still the most common weight loss operation performed today. And the way that it works is as follows. Remember, the human stomach holds 1 liter to 1.5 liters, and we take staplers and carve out a very small pouch at the very top about the size and shape of a small egg. And we separate that big old stomach from that little new pouch. We then find a spot on the intestines about 150 centimeters downstream, and we drag it up and connect it directly to that pouch. So after this operation, after 2 to 3 bites of food, that pouch is full. If you keep eating, you'll either stretch it out and have pain, or you can even throw up. So it physically is restricting how much you can eat. We then reconnect things downstream, and that's where the Y comes from. So the food is coming down that blue limb of intestine, that's called the RU limb, and those black arrows represent all the secretions made by the liver, the pancreas, and the stomach, the enzymes that are needed to digest your food. So the food hits the enzymes downstream, and that's where digestion and absorption and calorie intake starts instead of way up top. So that's how it delays how your body absorbs food. Again, it works in 2 different ways. It restricts and alters absorption. It encourages healthy eating with the dumping syndrome, and clearly affects hormones related to blood sugar, insulin, and appetite, like we've discussed earlier today. Most people will lose a significant amount of weight with this operation fairly rapidly also, and by all means, we really counsel people and say this is essentially a permanent operation. Theoretically, it could be reversed, but that's something that's extraordinarily rare. The gastric band is a totally different operation. This was very popular about 10 years ago, first done in Europe and then approved by the FDA in 2001. And what this operation involves is essentially putting a rubber donut around the top of the stomach, creating that little pouch up above. And the concept was, if a couple of bites of food fill up that pouch and cause it to distend, make you feel full, that's going to send the signal to your brain saying, I'm full, instead of having to have your entire stomach being stretched out to get that same feeling. This was adjustable. That was also one of the selling points of it. You can take fluid in and out to both inflate or deflate it. It did not require any bowel entry. We're not rearranging any part of the intestine. And it was also removable. There's no question this is the shortest and safest of these procedures, but it's also the least effective. It's done laparoscopically, and that little graphic up there shows how we actually adjust the band. Once it's in place, we wait a couple weeks to let the swelling from surgery die down, and then in the office, you go in about once a month, and depending on how full you're feeling and how restricted you feel, we would add just a little bit of sterile saline to that, and that would cause that donut to tighten, and essentially it was acting like a speed bump. It was slowing down how much you could eat and how fast you could eat. It's purely restrictive. It requires a lot of adjustments, so patients typically are coming in 10 to 12 visits for the first year. In the WAMI region, where we all take care of folks, that can obviously be a challenge if someone's coming in from Alaska for a 5-minute procedure. Really, we thought of this as a tool to manage appetite, and as we experienced, the worldwide experience with the band, we started noticing that it had high long-term complication rates, and more disturbingly, almost a 40% reoperation rate, meaning it had to be removed, replaced, or repositioned. So this technology really, I think, is going to be relegated to the dustbin of surgical devices. It's rapidly falling out of favor. It's still done in certain select patient groups, but really, I think it's on its way out. The sleeve gastrectomy is what has replaced it. So this is kind of the new kid on the block. In the surgical world, a new operation, less than 10 years. So this was first described by Michel Gagné in 2003, and it was initially part of a 2-stage operation. When we had really, really big patients, more than 350, 400 pounds, in whom we thought it was unsafe to do a bypass or a pancreatic diversion, we would first do this operation to get them to lose 70, 80, 100 pounds, and when they were slimmer and the surgical risk was more acceptable, surgeons would go back and do the definitive operation and convert it to a bypass. And what they noticed was about 85 to 90% of people didn't need that second stage. They were losing enough weight just with this operation. So that's when it started to be used as a primary weight loss procedure. This is technically a lot easier than a bypass. It does not involve any connections, and it preserves the pylorus, which is that muscle at the very end of the stomach before food enters the small intestine. And because we're not rerouting the flow of things through the GI tract, it reduces the risk of malabsorption and dumping. And also, there's lower risk of bowel obstruction because we're not working on the intestines down below. The way we do this operation, it's actually quite efficient. Once the patient's asleep, we have our anesthesiology colleagues place a soft rubber tube in the mouth down into the stomach, and that acts kind of like a template. We just follow the tube, put it in place, and staple right alongside it, and we take that part of the stomach right there and take it out of the body, and it's gone. So you go from a football-shaped organ, which holds 1 to 1.5 liters, to a thin tube kind of shaped like a banana, and we were able to achieve about a 90% reduction in the volume. So that final sleeve holds about the same volume as about half a can of Coke. This is obviously irreversible, right? We take that old part of the stomach and throw it in the trash, so there's no going back after this operation. How does it work? Clearly it's restrictive because we've reduced the volume so much, but a lot of research is showing that this actually may have some beneficial hormonal effects as well. When you take out the body and the fundus, which is that large part of the stomach up there, you immediately see a drop in ghrelin, so people are not as hungry. And both with this operation and with the gastric bypass, we also tend to see an increase in insulin sensitivity and better beta cell function. Beta cells are what make your insulin. And so that's a hot area of research trying to figure out how do these operations actually induce improvements in diabetes and weight loss through hormones. This is a very efficient operation, can be done in about an hour to an hour and a half. And one of the main advantages over the band, if we're comparing restrictive operations, is that it avoids a foreign body implantation, such as that rubber donut sitting in your body. All of these operations, when they can be done, should be done laparoscopically, which is really modern surgery in many ways. And laparoscopy is operating with those small little keyhole incisions and using an operating telescope and long, skinny instruments. There are some people that we cannot do that in. Their belly walls are too thick, which doesn't permit our instruments to work. Some people who've had a lot of prior abdominal operations and have a lot of scar tissue, sometimes that can make laparoscopy technically difficult or impossible. If we have to go the old-fashioned way, which is how almost all surgery was done for 100 years, with a big cut up and down the middle, that increases complication rates tenfold, especially as related to the wound. It'll easily double or triple the hospital stay, and it definitely puts more stress on the heart and lungs and also introduces a bigger component of pain control. So again, for all of these operations, if we can do it laparoscopically with little keyholes, that's definitely the way that we want to go. If you compare these three procedures, the band, the sleeve, and the bypass, they really fall kind of along a spectrum. If you look at typical weight loss, resolution of diabetes, resolution of high blood pressure, average cost, time of surgery, length of stay, and mortality, they really fall along a nice spectrum. And when a patient's trying to figure out which operation is best for them, it really requires a careful conversation with your surgeon, looking at what are the goals that you have, what are the risks that you are willing to take. And after an informed discussion, we work together as a team to come up with a good treatment plan for these folks. So which operation, if you leave tonight, which operation is being done the most? It's still most commonly the gastric bypass worldwide. This year was the first year that in the United States, the sleeve gastrectomy actually took over as the most commonly performed operation. So the sleeve is really exploding in popularity and utilization, and the band is quickly falling out of favor. So if we look forward at where most of the outcome studies and research are going to be looking, I think it's going to be comparing the gastric bypass with the sleeve gastrectomy. The next question is, which patient? We've kind of talked about which operation, and that is fairly black and white at this point. We still use criteria developed in 1991 by the National Institutes of Health, and they stipulated that gastric bypass or weight loss surgery in general should be offered to patients who had a BMI of 40 or higher, or between 35 and 40 with an associated medical problem related to their weight, such as diabetes, high blood pressure, sleep apnea, or joint disease. Besides those selection criteria, we have additional selection criteria here. We mandate that patients not use tobacco for at least 3 months prior to evaluation. Smoking can increase the risk of surgery. They should have no active substance abuse or psychiatric disease for at least a year prior to operation. They need to be an acceptable surgical risk. And really, to evaluate all these things, we do quite a thorough multidisciplinary evaluation. And that's what this consists of. We start with a 1-hour seminar, which is kind of a group information seminar with the surgeon. Then they go on for an individual consultation with the surgeon. And initially, if they look to be a reasonable candidate, we enroll them, and we then do a multidisciplinary evaluation, which consists of the following. Every patient gets a social work evaluation, nutritional consultation, physical therapy consultation. We'll check blood work, and also if we have to order some testing to look in the stomach or perform some imaging studies, we'll do that. If patients have significant systemic disease, we'll often get our medical colleagues involved to help us assess their risk for surgery. And once all of this is done, we bring the patient back for another visit with the surgeon where we go over the results of everything and then make a final determination for surgery. Once that's done, we then go ahead and do more teaching on the post-operative diet and get them prepared for the operation. And finally, we get them to the operating room. And this process can take 2 to 5 months. So this is a pretty long process, and it takes that long to finally get to this. And for a lot of people, this is one of the biggest days in their life. A lot of these people have been big, overweight people for their entire lives, and finally they're getting to the point where they're doing something about it. So there are a lot of emotions involved, and in some ways, we're kind of like the primary care doctors of surgery. Most surgeons and operations, once you do the operation to take care of an acute problem, once that patient is healed, they leave your practice. Bariatric patients are our patients for life, right? We're permanently changing their gut, how they eat, their metabolism. So we follow them for life. We see them about 6 or 7 times the first year, checking blood work, labs, and having them see our nutritionists to make sure that they're on target with their weight loss and not developing problems. Once they've gone beyond the first year, if they're doing well, we see them once a year after that. This is a unique operation. It's elective, right? No one needs a weight loss operation. It's not like cancer where you've got to go and cut it out no matter what. This is, well, not always, as Dr. Sinanan would tell you. These are elective procedures, but they're very invasive. They're permanent. They can have wide-ranging consequences, both good and bad. So you've got to be careful how you offer these procedures. It's better to consider these procedures in younger people. Younger people tend to have lower complication rates, lower risk of dying. Certainly, they have more to gain, right? If I did this operation on a 70-year-old, even if we improve their weight and get rid of some of their medical problems, we're unlikely to affect the final trajectory of their expected lifespan. On the other hand, if we take a 30-year-old who's got diabetes, high blood pressure, and sleep apnea, and we do an operation and get rid of those 3 medical problems, they're going to live for the next 4 to 5 decades without the continual slow onslaught of those diseases. So we have a chance to actually extend life with these operations if we do it at the right time. It's very important to involve the primary care doctor. They help us with preoperative evaluation, optimizing the health of the patient prior to surgery, and they're certainly part of the postoperative care team as well. So that's kind of what we do in a nutshell. I'm going to conclude with just a couple of slides on where the field is going. We've gone from open surgery to minimally invasive surgery. The next paradigm shift might be from minimally invasive surgery to endoscopic therapy, or procedures that can be done with a GI scope that you put through your mouth, scarless surgery, so to speak. Some devices that have been looked at include inflating a balloon in the stomach, which I'll show you a picture of soon, mimicking a sleeve gastrectomy by putting a special device in through the mouth and sewing on the inside of the stomach to create a sleeve. The duodenal jejunal bypass sleeve is like putting a long condom into the front part of the gut, and the goal of that is to actually mimic a gastric bypass. I'll show you a picture of that in a second. And then really I think the holy grail is pharmacologic treatments. If we can figure out the mechanisms with how these operations work and mimic that in a pill, we might be able to produce some of the weight loss effects and certainly some of the cardiometabolic improvements that we see as well. This is a picture of that duodenal jejunal bypass balloon, and the concept of that is we talked about with a bypass, we're basically excluding the front part of the gut because we bypass it. This involves putting a non-permeable membrane for the first 60 centimeters of the gut, so food is actually not touching the lining of the intestine, and it goes through. And they've done studies on these, and actually one of the first things they see is a remarkable improvement in diabetes, just as is seen when you do a gastric bypass. The picture there on the right is an intragastric balloon, and that involves going down, inflating a large balloon inside the stomach to basically to occupy space so that you have to eat less food to feel full. These are still things which are under research and consideration, so they really haven't hit prime time yet. Some other future directions and some of the challenges, possibly the use of these operations in new patient populations. Elderly patients to some degree and adolescents. We've recently started a collaborative with Children's Hospital, helping them manage some of their morbidly obese adolescents, and it's likely we'll start to do some of these operations on people who are between 17 and 19 years old. Also, we're talking about diabetes in the first 2 lectures. These are operations that can have a significant impact on diabetes, and that may be a future indication is to do one of these operations in a type 2 diabetic patient who does not happen to be morbidly obese. Advocacy continues to be a challenge. Only 1% of people who would qualify and potentially benefit from these operations actually get them. I'm not saying that the other 99% should, but clearly there's a discrepancy in what is offered by our healthcare system and insurance providers in relation to the number of patients who could potentially benefit. And as always, we're looking for long-term follow-up data to continually assess the efficacy, the durability, and safety of these newer treatments and procedures to help us make more informed choices for our patients as we go along. So with that, I'll conclude, and thank you all very much.